Good morning, CIMVHR Virtual Forum participants. I'm Dr. David Pedler, Scientific Director of the Canadian Institute for Military and Veteran Health Research. Welcome to the fourth and final day of our oral presentations that will begin with a keynote presentation by Dr. Barbara Rothbaum, Director of the Emory Healthcare Veterans Program, followed by Public Safety Personnel Session A and Veteran Session B. Before we begin, let's acknowledge the Indigenous peoples of all the lands that we are on today. While we are meeting virtually, I would like to take a moment to acknowledge the importance of the land which each of us call home. We do this to reaffirm our commitment and responsibility in improving the relationships between nations and to improving our understanding of our local Indigenous peoples and their cultures. Before I introduce today's featured speaker, I will invite Dr. Cécile Maradier-Jablou to say a few words.
Merci David. C'est un grand plaisir de présenter en tant que vice-rectrice à la recherche le Collège militaire royal du Canada, qui est l'une des institutions fondatrices de l'Institut canadien de recherche sur la santé des militaires et des vétérans. Nous connaissons les particularités liées à l'expérience militaire, autant pour les membres en service, les vétérans, ainsi que pour les proches. Nous explorons aussi les besoins spécifiques des professionnels similaires, tels que les premiers répondants et bien d'autres. Les présentations de haut calibre qui vont vous être présentées montreront à quel point la recherche émergente prend en compte les besoins différents des femmes et des hommes, et comment la recherche détermine souvent les politiques. Ces avenues et bien d'autres vous seront présentées ici au forum au cours du prochain mois. Nous vous y attendons en grand nombre. Bon forum!
And it's now a great pleasure that I get to introduce a colleague and longtime CIMVHR collaborator, Dr. Nicholas Carlton. Dr. Carlton is a professor of clinical psychology, a registered doctoral clinical psychologist in Saskatchewan, and is currently serving as a scientific director of the Canadian Institute for Public Safety Research and Treatment. Nick, please.
Thank you very much, Dr. Pedler. Good morning and welcome to all. I'm Dr. Nick Carlton, and I have the privilege of serving as the scientific director for the Canadian Institute for Public Safety Research and Treatment. I want to echo Dr. Pedler's land acknowledgements and acknowledge that the University of Regina is on Treaty 4 lands with a presence in Treaty 6. I also want to underscore my gratitude to CIMVHR for allowing us to be part of their fantastic forum again this year and to congratulate everyone on another terrific success. Facilitating collaborations between academics, researchers, clinicians, frontline members, leaders, and stakeholders is key to all of our shared success as we work to support the mental health and well-being of our frontline personnel, their leaders, and their families. I encourage all of you to visit the CIPSRT website for the latest updates on our progress. Before I introduce today's keynote speaker, I will mention that the presentation covers content that may be disturbing to some people. If you find you're becoming upset, please take a break to take care of yourself. If you need to speak with someone, a series of supports are posted on the announcement page of the conference platform. I'm now extremely honored and delighted to introduce one of my own academic heroes, Dr. Barbara Rothbaum. Dr. Rothbaum is the director of the Emory Healthcare Veterans Program, a professor and associate vice chair of clinical research at Emory School of Medicine in the Department of Psychiatry and Behavioral Sciences, and director of the Trauma and Anxiety Recovery Program. And she currently holds the Paul A. Janssen Chair in Neuropsychopharmacology. Dr. Rothbaum specializes in research on the treatment of anxiety disorders, particularly PTSD, which she has been studying since 1986. She has authored over 400 scientific papers and chapters, has published 11 books on the treatment of PTSD, and edited 4 others on anxiety. In 2010, she received the award for outstanding contributions to the practice of trauma psychology for APA Division 56 and the Robert S. Loeffler Award for Outstanding Scientific Achievement from the International Society for Traumatic Stress Studies. She's an inventor of virtual reality exposure therapy and pioneered its application for treating PTSD in combat veterans. She is past president of the International Society of Traumatic Stress Studies, is currently on the scientific advisory boards for the Anxiety Disorders Association of America, the National Center for PTSD, and the executive committee of the Warrior Care Network. Her recent book entitled PTSD, What Everyone Needs to Know, includes trustworthy, research, evidence-informed content on PTSD, made accessible to academics and general audiences alike without compromising the rigorous ways that we all rely on support for everyone's well-being. Please join me and welcome Dr. Rothbaum.
Hello from Atlanta, Georgia, and I'm honored to be here today talking to you. First, my disclosures. I am full-time at Emory, but when we started doing the virtual reality research, Emory took us by the hand to incorporate, and that's Virtually Better, and I'm a part owner. The virtual Iraq was created by Dr. Skip Rizzo at USC, not Virtually Better, and the Emory Healthcare Veterans Program is supported by a grant from the Wounded Warrior Project, which we're very grateful for. This is old data at this point, but it still influences my thinking. We conducted a prospective study meeting with adult female rape survivors right after the assault and assessing their PTSD symptoms every week for 12 weeks for 3 months. We were surprised to see in that first week following the assault, in the first days after the assault, 94% of them met symptomatic criteria for PTSD. So what that said to us was that the symptoms of PTSD are part of the normal response to trauma. Somebody holds a knife to your throat and says, "Don't scream or I'll cut you," you're going to have problems sleeping, trouble concentrating, be scared to go out by yourself. That's normal. We wanted to find out when a normal response to trauma ended and a psychopathological response that requires a diagnosis and treatment began. So we followed people over time, and we were again surprised to see 12 weeks later, 3 months later, almost half met full criteria for PTSD. So then what we did is divided it up and went backwards. So the top line represents people who end up with chronic PTSD. The lower line represents people, if you want to use the term recover, we can use that loosely, that don't end up with chronic PTSD. And now it tells a little different story. Everybody comes down a lot in the first 4 weeks. After that, the people who recover improve steadily across time. Whereas if you look at the upper line, the top line, the people who end up with chronic PTSD, after week 4, they don't change. They don't get worse, but they don't get better. And so this has led some of us to think of PTSD as a disorder of extinction. Fear and anxiety is a normal response to trauma. For most people, that fear will extinguish over time. For a significant minority, it won't. The good news about that is we know a lot about extinction training from the animal literature. In humans, we call it exposure therapy. Simply, what that means is we're helping people to confront what they're scared of, but in a therapeutic manner so that it changes. And that's really important, in a therapeutic manner so that it changes. We conduct evidence-based treatment. And so part of that is describing treatment so other people can replicate it. And we've done that in these treatment manuals for prolonged exposure. There's also an online course, and the bottom coupon code will get you a discount if you want to. And we think in terms of an emotional processing theory. The idea behind that is when something important happens to us in life, we need to emotionally process it. I make a lot of analogies to the grief process. There's really no way to the other side of the pain but through it. And if we process it, it will always be something terrible, but it doesn't have to intrude on our daily lives. It doesn't have to be as intensely painful. But for various reasons, sometimes people who end up with PTSD, they avoid it. And then they don't process it. And that's how it comes up to haunt them. And that's how I see PTSD, is that people are haunted by something that happened to them in the past. And we think for good emotional processing, what you need to do is activate the memory. You want to bring it up, but you want to put it back differently. You want to correct it. We've got a number of ways to do that, to activate the memory. One is imaginal exposure, where we ask people to go back in their mind's eye to the time of the trauma and recount it out loud repeatedly. We do in vivo exposure, which means in real life, and I'll talk a little bit about virtual reality exposure today. I'm not going to review the whole literature on exposure therapy, but it's got more evidence for its efficacy for PTSD than any other intervention. So now let's switch to some new approaches and virtual reality. And you're seeing the virtual airplane, which is actually my favorite environment. I can exactly control stimulus. If my patient's not ready for turbulence, I can guarantee there won't be turbulence. If my patient is ready for turbulence, I can guarantee there will be turbulence. We can take off and land as many times as we need to, all within my 45, 50-minute therapy session and without leaving my office. This is an early version of the virtual Iraq, and I'll show you a more recent version. So virtual reality, what is it? It is a computer-generated multimedia environment, but it's more than that because the user feels immersed. They feel present in that environment. They're wearing a head-mounted display, which is, you see one version here, an older one, that's basically a strappy helmet with two television screens in front of each eye, earphones, and a position tracker. So just as my view changes in reality when I move my head, so it does in virtual reality. The therapist can see everything on the monitor that the patient's seeing, so we can comment appropriately. For some environments, there's a joystick or a handheld tracker, for example, to drive the virtual Humvee. They are on, you see this raised platform with a base shaker, so they can feel, for example, the Humvee's engine. They can feel the landing gear coming up in the airplane. This is what it looks like at the Emory Healthcare Veterans Program, our setup. And this is what it looks like just in a regular office. We published the very first study using virtual reality to treat a psychiatric or psychological disorder in 1995. And that was for the fear of heights. This was the original elevator we used, modeled after the Marriott Marquis. This is an elevator we used in the decycloserine studies about 10 years later. And this is what the elevator looks like now. These were the original bridges in the 1995 study. And these are the bridges now. We've got environments for addictions, for fear of public speaking. This is a virtual crack house. We've done studies using it as a distraction for kids when they're undergoing painful procedures. In this first study, it was just a crude virtual gorilla environment modeled after Zoo Atlanta. Now it's a much more beautiful and engaging environment. For social anxiety disorder, the therapist can control the audience's reaction. So they can be very enthusiastic, like, I love this guy. We can make them stony face. We can have cell phones going off, people standing up, raising their hand, asking questions. We can load their talk as a PowerPoint into the podium. We can use videos of real people, or we can use avatars. And here I told you the fear of flying. Of course, we modeled it after the Atlanta airport, the busiest airport in the world. And like on a real airplane, most of what happens outside the window. In a couple of studies, we compared the virtual reality exposure therapy to using a real airplane. So VR is the virtual reality, SE is standard exposure therapy using the real airplane, and WL is weightless. And you can see that both treatments are equally effective. In one study at the follow-up, the 12-month follow-up, 90% of people in both treatments flew. And you can see their SUDS, subjective units of discomfort, indicate comfortable flight. So it really is very useful. There is a version available in a smartphone, and this is what that looks like. Now, getting back to PTSD. First time anyone had done any use virtual reality for PTSD, we tried it with Vietnam veterans, and we created two environments, a virtual Huey helicopter that could follow a river, go over rice paddies, fly over a jungle, and a clearing surrounded by jungle that most of our guys referred to as a landing zone. It's hard to tell, but that's a real digital image of a Huey helicopter. And what we did was imaginal exposure to their most traumatic memories of Vietnam, but now immersed in this Vietnam stimuli. And now a lot of people around the world are using virtual reality to treat PTSD, including my colleague Joanne DeFede, who has a virtual World Trade Center that she uses to treat survivors. They use it in Israel to treat survivors of terrorist attacks. This one is cool. It's used to treat driving anxiety and aggression in veterans. And the anxiety came down, and you can see on the right, the anger came down too. This is a study of another group in Florida who has a comprehensive treatment for veterans, and that's in red, and it works very well. And the dotted line is when they add virtual reality. It works even better. We treat, and we conducted a study using the virtual reality to treat MST, military sexual assault. I thought you might want to see, this is what the therapist sees. This is how we control it. It looks very confusing, but it's really not that bad. All of the scenes that we have to choose from are on the right. And what we're doing is picking a scene that matches what the patient describes. We can change the time of day and the brightness, again, to match what the patient describes. We can manipulate doors and lights. And as you can imagine, it's very scary if you think you're alone in a room and you hear a door close behind you, and we can manipulate the sounds. It worked. This is on the CAPS, clinician administered PTSD scale. Their PTSD reduced. We also like to look at psychophysiological outcomes, and we saw significant decreases in their heart rate in response to cues. Now getting to the virtual Iraq. This study was published in 2014 in the American Journal of Psychiatry. And this is just a little clip showing you some of what we can do. You're seeing it as a movie, which isn't how we show it to patients. They're seeing it in the head-mounted display, and we're only showing them what they're describing. So if they're describing at a checkpoint, that's what we would show them. Driving back to base, I'm in the turret, that's what we would show them. So we are matching what they describe. And we can match almost whatever they describe from Iraq or Afghanistan. We can put them in an MRAP or a Humvee, checkpoint, fob, medevac them out. We've got a city, if they're on foot patrol with 3 different mosques, they can go in. We can put them whatever position they were in the vehicle as the driver, passenger, backseat, or the turret. If they were the gunner, we can change the time of day. So again, we're doing imaginal exposure to their most traumatic memories from Iraq or Afghanistan, where we ask them to recount it out loud repeatedly. We record it, and the therapist is matching in the virtual reality what the patient is describing. In this study, we underdosed the virtual reality and added medication before each session, either D-cycloserine or pill placebo or alprazolam, Xanax, low dose. And in general, we saw significant decreases in PTSD, which we were glad to see since we were underdosing the virtual reality exposure therapy. As far as the drug conditions, the consistent finding was that the patients who received alprazolam, Xanax, did worse on PTSD severity at post-treatment and diagnosis at 3 months. So benzos are not a good treatment for PTSD. We've known that. We also, as I said, measure psychophysiological responses. And one that we like to measure is the startle response. And you may not realize it, but every time you startle, you blink your eyes. And so we can measure that in heart rate and skin conductance. And we saw the startle response decrease during VR scenes with treatment. And that makes me really happy, because I think one of the things that can make people with PTSD feel crazy is they can know they're not in a war zone, yet their bodies are responding as if there's the same level of threat. And so I like it when I see that their bodies are learning to become less reactive to cues. We also measured their salivary cortisol, stress hormone, before and after these VR assessments. And as expected, the cortisol increased right afterwards. So now this is what I just showed you. And that difference between before the VR and 15 minutes afterwards is what we're calling cortisol reactivity. And you can see that that decreased with treatment and stayed lower 6 months after treatment. So again, their bodies are learning to become less reactive. So everybody's asking me about psychedelics and the treatment of especially PTSD. We've been doing work for a few years with Mdma, and some of the first studies that came out, this is the environment where they do the Mdma assisted therapy. It's very sweet. I think of it as the sweetest PTSD therapy out there. What we do is effective, but I wouldn't call it sweet. And in this first study, they saw significant decreases with Mdma, and then in the crossover group after placebo, they saw the significant differences. When this came out, this is really what influenced me, because this was a long-term follow-up, almost 4 years, and the improvements were maintained. This is a fairly recent study. There is no placebo here. There are 3 different doses, and the 75 milligrams actually looks like it's the most effective dose. We like doing translational research, so we'll test something in animals and healthy humans and then go to patients. In our animal studies, we found that Mdma facilitated the extinction of fear in a rodent model. We also found that SSRIs inhibit that effect. So that's kind of lousy, because most of our patients come to us on SSRIs, but it's important to know, because if we're going to use the big guns like Mdma, we want to make sure that we optimize the chance of success. This is, I always find it interesting. This is where the rodents are. Then we switched to healthy human studies. And remember, we view PTSD as a disorder of extinction. And we can measure that with the startle response. We use pretty much the same paradigm that we use with the animals. So on day 1, we did the fear conditioning. On day 2, that's where they're dosed, either Mdma or placebo. And they received the fear extinction training. Then we bring them back 2 days later, where we test extinction recall. And this is what it looks like. The aversive stimulus is a blast of air to the larynx. It is obnoxious, but not painful. And looking at their vitals, the dark squares are Mdma, and you can see pulse rate and blood pressure is up. Everyone acquired the fear potentiated startle. Everyone discriminated beautifully between the safety cue and the danger cue, and both groups demonstrated beautiful extinction. Remember, these were absolutely healthy, normal adults. What we found in looking at the extinction retention is there were more extinction retention responders in the Mdma group than in the placebo group. So natural next step for us is combining Mdma for PE, prolonged exposure in PTSD patients. And we're trying to get funding for that now. A lot of people are asking about psilocybin, magic mushrooms. And a lot of the work has been done in depression for psilocybin. And you can see that it's been led to more improvements than placebo in depression. It was also designated in 2018 as a breakthrough therapy. So it is looking promising as well. So now let's switch to another innovation, the timing of exposure therapy and early interventions. PTSD is the only anxiety disorder in which an external event, the trauma, is part of the definition, the diagnostic criteria. So unlike other psychiatric disorders, the precipitant for adult PTSD is a known event, and that allows us to do something right afterwards in that aftermath, potentially to prevent the development of PTSD. So we've been doing a series of studies in the emergency room at an inner city level 1 trauma center. And we started an early intervention right there in the emergency room, hours after they experienced a traumatic event. The blue represents folks who received the early intervention. The yellow are people who were just assessed at the same time points. And at week 12, 3 months after the traumatic event, the people who received the early intervention had half the rate of PTSD as the folks who were just assessed. And this is complicated, but the gist of it is, it looks like it mitigated a genetic risk for PTSD. We're also working on an app, calling it Messy Memories, that can do some of the same thing. It's for potentially traumatic events, but also life's lousy moments and things that we can't quite get over on our own. And obviously, these are interventions that we would want to be able to use in theater, in the field. Last innovation I'll talk about is the treatment schedule and looking at MAST PE in the Emory Healthcare Veterans Program. We have two formats. One's regular outpatient therapy, generally coming about once a week. The real innovation is our IOP, a 2-week intensive outpatient program. We can bring veterans in from all around the country. We fly them in, put them up at the hotel across the street, and give them a lot of therapy every day for 2 weeks. Everything is at no cost to the veteran. We give them a lot of exposure therapy. We work with their families. This is our building. Everything that they need is right here in the building. They don't have to leave for anything except the gym. We treat PTSD, TBI, MST, depression, anxiety, give them a lot of psychotherapy, pharmacotherapy, cog rehab for folks on the TBI track, stress management. We've got a sleep doc who works with us, and we've got a sleep lab in the building. Everyone gets yoga and training in wellness. If they've got pain, we can give them acupuncture. We include families in therapy sessions, but via telemedicine, even before COVID. We didn't bring them on site, and we help them navigate the VA system. This is probably the best slide, my favorite slide I have to show you. You probably know in regular PTSD treatment, a lot of people expect about a 50% dropout rate. PTSD is a disorder of avoidance. We have a better than 93% retention rate. I've really come to believe this is the way to treat PTSD. And they're getting a lot of therapy during those 2 weeks. When we looked at 2,000 patients that we served, they received 28,000 sessions, 33,000 hours of session. They're getting a lot of therapy, and it's effective therapy. This is the Pcl Ptsd Checklist. And you can see this first part of the line. This is that 2-week period, pre and post the IOP. And then we follow them for a year afterwards. So they're achieving good gains in treatment, and then they're maintaining them. And similarly for depression as well. They're achieving great gains during treatment that they're maintaining. We just published this year. As you would imagine, when you treat the PTSD effectively, the suicidal thoughts decrease. So many people, as we've been talking about this IOP, have asked us about it, that again, we do evidence-based medicine. So we published a manual on the IOP that's available. And as I mentioned, we have a SUD track and a TBI track that are very effective. And this is a shameless plug for our latest book, PTSD, What Everyone Needs to Know. You can get it on Amazon, it's cheap. Buy it for everyone on your holiday list. Some of the conclusions, and we'll have a few minutes to talk about things. A lot of excitement is around about Mdma. It's not a magic pill. The way we're proposing using it, if we get funding, is for veterans who have been through our IOP and haven't received a full response. And so we know they got a good dose of good evidence-based therapy. They tried hard. So we need to try to do something to enhance that response. That's who we're thinking is a good candidate to combine Mdma and PE. At the end of the day, there are probably going to be different types of PTSD, and there'll probably be different treatments for these different types. We need more options. Always, we want good options. And so MDMA can be an option to help us personalize treatment. We already have excellent treatments. Nothing works for everyone, but we always think that people should try one of the evidence-based treatments and delivered with fidelity, how it was meant to be delivered, before you go to one of these newer therapies, and maybe use a stepped approach. Start with an evidence-based therapy, and then if it doesn't work, you can go to something like MDMA. Feel free to connect with us. And with that, I'll sign off and we can have some questions.
Thank you so much for your presentation today, Dr. Rothbaum. That was extremely interesting, timely, and engaging. Every time I have the pleasure and privilege of listening to your lectures, I learn something new, and I enjoy new ideas for opportunities to contribute to evidence-based research and practice. This brings the main plenary for public safety personnel to a close. I would like to invite all of you to join PSP Session A, join Veteran Session C, or switch between the two for the rest of today's oral presentations. Once again, there is a 5-minute buffer between this main plenary and the start of the next sessions. If you run into any technical difficulties, please don't refresh. You will enter the session shortly. Thank you again for your attention, engagement, and support. I hope you enjoy the next few hours of research presentations. Thank you.